Thank you so much for having me this afternoon. My name is Emily Graban. I am the Divisional Director for Acute Care Services at the Office of Licensure and Certification with the Virginia Department of Health. Hi, Office of Health Equity. So I'm really happy to be here just to talk to you a little bit about it's just some of the trends that we've been seeing in our office in regards to the survey process. So when we talk about survey process, we're talking about federal certification through CMS, which all of you are federally certified. We primarily do certification surveys every 6 years for those that are not deemed or accredited. And then we do conduct complaint surveys on deemed providers as well as non-deemed providers, but we do have to get CMS, the regional office in Philadelphia, they have to approve for us to go out to conduct a complaint survey on a deemed provider. That doesn't happen a whole lot. We don't get a lot of complaints from rural health clinics, and up to this point this year we've received none, so good job for you guys. And I got a question. I wanted to address this really quick before I get started. But every 6 years is when you would see us if you're not a deemed provider, and so we are running about 6 to 8 weeks behind, which is better than some of our other counterparts in regards to state agencies. But one thing, we really have seen a huge influx in hospital complaints, and so that's what's been keeping us from getting to you all. Another piece of that too is my team, so basically in our office we have 5 state licensure programs. I oversee 4 of the 5 state licensure, and then we have about 10 federal programs that we run. So if you have a question about anything that's not a nursing home, I'm the person to ask, because my team specifically oversees everything but nursing homes. But what's kind of weird is I'm a nursing home administrator, so I don't know how that happened, but it just happened. So I just wanted to make that clear, just to kind of show you how our office is delegated and how it's broken out. And we have about 150 surveyors, we call them medical facilities inspectors, who are out in the field that are conducting these surveys and inspections for our state licensure programs. My team specifically, we have 2 acute care supervisors that oversee rural health clinics, and they have 12 surveyors on their team. So just to kind of let you know a little bit more about us. So because we are the right hand to CMS's left hand at the state agency, I'm going to be specifically talking about Appendix G of the SOM. So just so that I know you all are very well aware of Appendix G. What I want to focus on is not everything, but again, just what trends have we been seeing recently when we've been out to facilities. And a lot of them are going to mirror Kate's presentation, so I do apologize if there's a little bit, we didn't talk beforehand, but you think that we would have. But it's good validation, and I think it's just another point to bring home to you all that these are the things that if you have to prioritize what you're going to work on, that these things might be the ones that you want to prioritize. So we're going to talk a lot about emergency preparedness, staffing and staff responsibilities, especially just the specific roles that each staff member does need to have, as well as medical director oversight, provision of services. We're going to talk specifically about an immediate jeopardy that occurred in one rural health clinic that we conducted a survey in last year. Patient health records, this is another really big one, is just making sure that you've got your program in place and that you're reevaluating it. And then the CMS COVID vaccine final rule. So I have just a couple of additional things to add in addition to what Kate said. So this is what kind of our roadmap for the next hour. So emergency preparedness. So when we go in to look, we want to make sure that we see each of these components. So we want to see your specific policies and procedures. We want to see that your risk assessment has been completed and it's up to date, that you have a communication plan, that you have a training program, and then you also have a testing program. So we're going to break it down into each category of the specific emergency preparedness plan. So the risk assessment. We are going to look for a risk assessment that is specific to your clinic. So a clinic in Duffield might have a different one than outside of Roanoke. And that's okay because you serve different populations. So that's one of the key components of your risk assessment. It needs to address your patient population. And then you also need to make sure that you are coordinating your local emergency plans with like local, regional, state, and federal emergency preparedness officials. Now, that sounds official, but what we're looking for is that you have made an effort to reach out to these other outside entities to assist with your emergency risk assessment. And then the plan must include documentation of your efforts to contact those officials. So again, I put that on there because that is really what we are looking for, that effort. And then your communication plan needs to be broken down into the names and contact information, again, for your staff, also for any other entities that are providing services, so your contracted services, the patient's physician, and then also their primary care physicians if the medical director is not their primary care physician. And then other rural health clinics, it's always a good idea to reach out to them. If there's any that are close by, see what their risk assessment, their communication plan, what their emergency preparedness plan looks like, and coordinate with them. In the nursing home world, this is something that they do constantly when you're preparing your emergency preparedness binder, is making sure that your sister facilities could absorb any patients or residents and vice versa. And then you also, again, want to have contact information for any of your federal, state, or local emergency preparedness staff. That could also include EMS if you feel that that's necessary. And then any primary and alternate means for communication with those entities. So, what is the means of providing information on the general condition of the patients under the facility's care is what the regulations is stating. So now that you've got your policies and procedures, you've conducted your risk assessment, now we need to talk about your training program. So initial training, what that program looks like, does need to be part of your policies and procedures. So how are you going to train all of your staff that you have right now? And then what does training look like for any new hires? And then what does it look like on an ongoing basis? Keeping in mind that this could also mean contractors. We do also put the term volunteers in there if you do have volunteers. Emergency preparedness training, we're looking for that it is done annually, and it must be documented. So again, making sure that you're keeping your binders up to date, that you have sign-in sheets. Those are the types of items that one of my inspectors is going to look for. Yes, sir?
You said annually.
Mm-hmm.
Even though everything else seems to be biennial, you want the training to be annual.
The training needs to be done annually.
Okay.
Because it could change. And that goes back to one of the questions that you had asked earlier. I think I may have interpreted your question a little differently than maybe what you were asking. And so it goes along with your tabletop exercises too. Think about that. That's part of your overall, not only your program evaluation, but it's also a training opportunity as well. If you have had a live emergency event, per the CMS regs, you could skip a year. And you don't have to do that. So yeah, we are looking for it to be done annually. But overarching policy and procedure review has to be done biannually. And then how do you demonstrate that your staff are actually going to be able to implement your emergency preparedness plan in the event of an actual emergency? So we're looking for that too. Your testing program. So you must conduct an exercise to test the efficiency or the effectiveness of your emergency preparedness plan. So this is where it goes to your full-scale exercise. So what we're looking for is that you're participating in a community or facility-based full-scale exercise. If you experience an actual emergency where the plan is activated, you're exempt from a full-scale exercise for 1 year following the onset of that emergency. So making sure that you have that documented is what we're going to look for. And then you also need to conduct one of the following: a second full-scale community or facility-based exercise, or you can conduct a tabletop exercise. We can't prefer one over the other, but wouldn't it be wonderful if you had 2 full-scale exercises and you felt that you were prepared? But we do understand that time is very important, staff availability, so that's why the tabletop exercise is acceptable as well, but making sure all of that's documented. So again, I couldn't say this enough: document, document, document. Maintain your documents of your drills, your tabletop exercises, and any other adverse emergency events that you do have. You want to make sure that you've got all of that readily available. When I was an administrator, I had all of it in one notebook. It literally was like one of those big ones that you get at Office Max, and whenever my inspector showed up, I just handed that to them, and it had everything, a table of contents, and it was separated by dividers. So this slide, I know it looks like a lot, but there's kind of a purpose and a method to that madness, because I want you to see this is for one facility who did not have an acceptable emergency preparedness plan based off of everything. They didn't have correct policies and procedures in place. They didn't have an evaluation program. They didn't have a testing program. They didn't have a training program. So they ended up getting 10 standard level deficiencies because we did cite them on everything because they just simply didn't have it. So keep that in mind as well, is that there are a lot of components to emergency preparedness that we're going to expect that we'll cite all 10 of these, and we would expect they had to do a plan of correction, but it was for an IJ. So it seems like a lot, but it is. I mean, that's how important it is. Okay. So moving on to staffing and staff responsibilities. So again, just to mirror what was already mentioned, is the 50% rule. We also are looking for that. We're going to pull schedules. We want to pull your actual worked schedules, and we'll take a look and calculate to make sure that you've got that 50% coverage. Keep in mind that we don't require the medical director to always necessarily be on site. Especially now with the last couple of years that we've been through, telemedicine is something that's been very helpful, I think, to the rural health clinics as well. So especially if you have a medical director that's been working doing telemedicine, we don't require that he's there as long as he or she is there as long as these other components are met. And then a physician assistant or a nurse practitioner can perform functions to the extent that are not being performed by a physician. So I know most of you are probably very well aware of that. The issue that we have run into in the past, and we'll talk a little bit more about this in regards to my deficiency example, is that when doing chart reviews, we noticed that since May of 2018 that the medical director had not reviewed or audited any of the patient medical records in this particular clinic. So that ended up being a deficient practice, of course. But that's one thing that's really important. We talk a lot about the policies and procedures. So whatever policy and procedure that you have in place for medical director oversight, we're going to review that, and we're going to make sure that you're compliant. Okay? So again, my deficiency example. So based on observation, interview, and medical record and clinical documentation review, we found that there was no evidence of medical director supervision of the nurse practitioners in this particular clinic, that the physician providing medical orders, there was no evidence that the physician was signing off and providing medical orders and medical services to the patients. And then there were no periodic chart reviews. I think I said May, I meant March of 2020. So they began the pandemic, and we surveyed them in September of 2021, and so there had been no medical director oversight during that period of time.
Emily, can I ask a question?
Yes.
Does it need to be the medical director?
Yes, or if it's, yeah, it needs to be the medical director. Provision of services. So we were talking earlier about expiration of medications, but for this particular example, I wanted to talk about emergency medical procedures. So rural health clinics are required to first respond to common life-threatening and acute illnesses. And again, this can be based off of the population of your clinic. So this particular clinic had a very high rate of patients that they were seeing who were diabetic. They did not have glucagon on their crash cart. They didn't even have a policy on how to address a diabetic emergency. So there needs to be availability of drugs, analgesics, anesthetics, antibiotics, all of those things. You need to have a policy in place that says what is supposed to be on your emergency crash carts. The staff must also be able to handle those medications, of course, within their scope of practice. And then your patient care policies must address which drugs are going to be maintained on your crash cart. So we're going to refer to your policy and then check your cart to make sure that they match up. Again, consider your patient population. So this particular clinic, we went in and we noticed that all of their drugs had been expired since like 2018. Again, this is the same clinic that we saw in September of 2021. They also did not have a defibrillator on the premise. And they did not stock medications and biologics commonly used in life-threatening emergencies specific for their patient population. So the IJ was actually related to noncompliance with the provision of services due to failure to maintain adequate and current inventory of emergency drugs and equipment to handle common life-threatening injuries and acute illnesses as a first responder. Has anyone, I hope that nobody raises their hand when I ask this question, but has anyone experienced an immediate jeopardy before? Okay, so let me help you. Hopefully you'll never have to do that, but let me help you. So what happens next, right? So you're sitting in your RHC, your surveyor shows up, they said that they've called me. Unfortunately, they have to call me and I have to say yay or nay. They've called me and they said, we need to stop the survey and issue an immediate jeopardy. So that really does mean that the whole entire survey has stopped.
You had a defibrillator on there. Is that a Virginia regulation? Because it's not an Appendix G. So do we have to have a defibrillator in the clinic?
For life-threatening emergencies, yes, a defibrillator would be necessary. State required.
Okay, state required.
Yes, sir.
Okay, because federally it's not required.
Yeah, it's required by the state.
Thank you.
Yes, of course. So you're going to hear me use the term abate. So the first thing that you're going to do is you have got to abate your IJ. So what that means is that you need to have a plan of removal to remove the immediacy of the harm. So for this particular example, they updated their policy. They came up with a list of all of the updated medications that needed to be on their cart, including the name, the classification, the quantity, and the expiration date. They included in their policy that they will conduct quarterly audits on all of their crash carts. And that was either done by the administrator or one of the nurses that was in the clinic. If meds are used or expired, then the administrator is alerted immediately, who will then document that those medications have been removed from the cart and that they have ordered new ones. And then the administrator who is conducting the quarterly audits, that's the person that would order the new medications. And then the staff were going to receive BLS training, and they actually did purchase a defibrillator. So this was an acceptable plan of removal. So then what happens is that once the plan of removal is accepted, they then will receive a plan of correction. So this particular IJ was downgraded to a condition level deficiency. Now a plan of correction is required. So what you need to do for a plan of correction is the piece that we're really looking for is how are we going to prevent this from happening again? So that's the huge component, because now we've got to make sure that your IJ abatement plan becomes basically your policy, and that we wouldn't show back up again and we would see it. So what we would do on our end is we would conduct an unannounced revisit, but we're going to be looking specifically at just the IJ. We're not going to do a full-scale survey again unless you receive a complaint. Then we would have to do a full-scale survey again. The IJ then becomes non-compliance, and again, that plan of correction, so the description of the corrective action taken, the allegation of compliance date, which has to be 45 days, cannot be more than 45 days from the exit date of a survey, a description of the measure implemented to prevent reoccurrence, and then we will not accept a plan of correction if we do not have a signature by an administrator. Any questions on IJs before we move on? Okay, so patient health records. I don't want to read this to you, of course, but one thing that we did talk about is that there must be a designated staff member who is going to make sure that compliance is reached with patient health records. So it doesn't have to be a doctor, it doesn't have to be a nurse, it can be a member of your administrative staff. We're going to be looking for protection of your medical records. So are they, in a specific room? Are they in filing cabinets that are locked? Those are the things that we're going to be looking for. And is it confidential? And then retention of records. So we're requiring that records are retained for at least 6 years from the date of the last entry. So we're going to look for that too. To make sure that all the records that are either being stored there, is there an inventory list? If you don't have space, are they stored off-site? What does that look like? We just want to make sure that you're in compliance with the 6-year retention policy. Program evaluation, this is a big one too, making sure that every 2 years that you're evaluating your total program. So evaluation includes, utilization of your clinic services. Again, why would you wait 2 years to look at your business? I like that example, but we're requiring it every 2 years, including the number of patients that you've served, the volume of services that you've provided. We just want you to look at a representative example of current clinical records as well as closed records. And then also looking at your policies. I think this is one of the biggest ones. And anyway, when I was an administrator, we would do our QAPI meeting the first week of January. And everybody knew to come prepared because we were going to be doing our policy and procedure review. So, come up with a system that works well for you. And then documentation and making any changes that are needed, because, the only constant in healthcare is change, right? So, what changes are you making, and documenting it, and then showing us evidence of, why changes may have been made. So our deficiency example, this one is pretty straightforward. This is actually the same rural health clinic. So based on observation, they had papers sitting in chairs, they had papers sitting on filing cabinets, they had stuff everywhere, medical records everywhere. We were looking for a specific file that we had asked for, they weren't able to locate it. They were able to locate some files. They, of course, were incomplete because they had probably boxes and boxes of filing that needed to be conducted. Then we also found that, entries were not dated in time, and they were, of course, nothing was put timely into the medical record because there were piles of papers in the office. And then we're just looking to make sure as well that laboratory results are included in your medical record. And so for this particular clinic, they did not have their lab results in the medical record as well. We talked a little bit about this already. Program evaluation, so looking at your total program every 2 years. And again, just making sure that your services are appropriate. You've established policies and procedures, either new ones, making sure that they're being followed, your old ones, and then corrective action does need to be taken if necessary. The deficiency that was given to this poor rural health clinic, which they were so wonderful and so gracious and so willing to make changes. So I really, I just commend you all for what you do, because it's definitely not easy, especially when we show up. So again, we're looking for, this particular clinic didn't look at their program every 2 years as they're required to. So they didn't review 5% of their current patients. They didn't include a review of samples, of open and closed records, and they failed to evaluate their healthcare policies. So again, seems pretty straightforward, but again, this is another one that we're seeing more and more frequently. And then the newest regulation that we are all continuing to work through, as it's a fluid process. Any tags for the CMS COVID-19 final rule would go under staffing and staff responsibilities. So I did break it down so that you can understand what a condition level citation versus a standard level citation would look like. So we'll get to that in just a minute. The biggest thing, again, and I cannot say this enough, is that making sure that you have policies and procedures in place. That's what we're going to look at. Is we're just going to say, hand me your policies and procedures, and we're going to just get busy reading. Because we want to ensure that staff are fully vaccinated, and we identify staff, again, as employees of your clinic, your licensed practitioners, students, trainees, or volunteers if you have them, and then any individuals who provide care, treatment, or other services under a contract or other arrangements. So I'm sure that you all are very well aware of who needs to be vaccinated. So the policies and procedures must include, at a minimum, a lot, right? So a process for ensuring that your staff have received, at a minimum, the single dose or the first dose of a primary vaccine series before providing care to any patient. So the process also needs to state that you need to have a policy in place for staff who are fully vaccinated, except for those who've been granted an exemption or temporary delay recommended by CDC. So again, CDC is your friend on this one. We get a lot of questions, on what should I do about X, Y, and Z? And honestly, we're starting to refer more and more people to the CDC because that's what I look at. If I have a question about one of my inspectors going out who may have had exposure, the first thing I do is go to the CDC website because that's what VDH is following. And then a process for ensuring that the clinic follows nationally recognized infection prevention and control guidelines to mitigate the transmission of COVID-19. So that's really important too, is we know that vaccines help, but we know that it's not foolproof. So what is the process that you all have in place? A tracking and securing the documentation, again, because that is PHI, and a process by which any documents that support contraindication of vaccine are signed by a licensed practitioner. So we talked about that earlier, right? And then also, if there's a reason for delay, we have to have a tracking process and documented as well. So if you like we talked about earlier, if I was, pregnant or I've had monoclonal antibodies or I've had COVID within the last 90 days and it's not recommended that I get vaccinated, that's okay, but we need to see that you have a process in place to follow up with that individual. And then we talked about this too, a contingency plan for anyone that is not vaccinated by COVID-19. So surveying for compliance, this is where we step in. Again, I wanted to show you what it looks like from our standpoint. So if facility staff vaccination rates are 100%, that does unfortunately constitute noncompliance even if you're at 99%. Immediate jeopardy would be that 40% or more of your staff still remained unvaccinated. We have given immediate jeopardies, not in rural health clinics, but we've given them in home health agencies. We gave one at an outpatient physical therapy clinic because they were at 75% non-vaccination rates. Or you have 100% of your staff vaccinated, but observations show non-compliance with infection control practices. That would be across the board, whether it was related to COVID or not. That's another one that, you could potentially get an immediate jeopardy for is, breach of infection control practices. A condition level would then be it's very specific, so 21 to 39% of staff remain unvaccinated, or 100% vaccination rate and one or more components are missing from your policy and procedure. So again, we're looking for that complete policy and procedure. It's so important that we would give you a condition level deficiency if you were missing components of it. If you're missing one component of it, we could give you a condition level. And then a standard level, 100% of staff vaccinated, but your new staff have not received at least one dose or one or more components of your policy and procedures is missing. Or you did not meet 100% staff vaccination rates, but you're making a good faith effort, which means prior to us showing up, so not since we showed up, you're making a good faith effort, but prior to your survey taking place towards compliance, we would still give you a standard level deficiency, but we do understand that things are fluid in regards to this requirement. And I hope I didn't talk too fast, because that's all I had. Are there any questions? I put my contact information in here a couple of different times. I also left cards with Beth, so Sherry has them. So please, grab a card and, feel free to reach out to me with any questions or concerns. I'm always happy to help or at least get you going in the right direction for an answer. But
if we hire staff that want to get, for instance, a religious accommodation, so they're hiring them in, they don't have the COVID vaccine, does our policy need to say that we're allowing a grace period to give them time to obtain that?
as long as your policy states it and you have a tracking program in place to follow up, yes, we would accept that. Mm-hmm.
Can we get these slides?
Well, the only reason I ask is because if we hire them in, do we have to have the religious exemption accepted first before we can make the offer? Or
Before they can conduct patient care.
Okay.
Now, if they are not going to be conducting patient care or interacting with patients, they technically they don't have to be vaccinated. But before they provide patient care. So, I always kind of equate it to a criminal background check. Is you wouldn't want that individual treating your patients until you've got their file complete. So criminal background check, COVID exemption, vaccine card, et cetera.
Our facility had a third party approving the religious exemptions or the medical exemptions. So
Gotcha.
there was no
And that's not a
perception of us being involved in that decision.
There's
So
not a
there's
fast
that-
process, yeah.
So there's that period of time of which we have to submit it. So that's
Yeah.
why I was wondering.
No patient interaction though.
So like you mentioned, if it's a third party or like, and you know that there's a form or whatever the team member fills out, but you don't know all the complete details of how it's approved.
Make sure
Our organization, our corporate HR took care of the approval process
Mhm.
and the exemptions. We just rolled out, hey, you go here, you fill out this form, and from that, I don't know.
You don't know when it,
I don't
yeah.
know what their criteria was or how they determined that, so.
What does your policy say about, what did you do with those individuals while you were waiting to hear back about their exemptions?
Well, we had it all done in place before the election.
Oh, before the, yeah. So if that happened again, hypothetically, your policy would have to address what are you going to do with those individuals?
Right now, they have to be vaccinated before they can.
Right. I would say, that, well, I can't offer advice because I'm a regulatory agency and not a consulting agency, but I would advise that you have a plan or a process already in place before that individual signs their offer letter, to mitigate as much risk as possible from an infection control standpoint and a regulatory standpoint.
Playing with fire.
You are, and it'll spread quickly.
Yeah.
I mean, the thing is, we had a phase-in period, you know, and so they had time for corporate to do that kind of thing.
Right.
Now,
But now
now
you're,
there's no grace
Yeah. People can't do healthcare if they don't have vaccination or exemption approved. Pretty much.
yeah, and like so all of our federal surveyors have to be vaccinated, and we unfortunately had to let a couple go because we didn't have a state licensure team for them to go on. So, yeah, it's and with the Virginia Department of Health, it was you got to get it done like now, so because we had to meet the same guidelines. Any other questions? Thank you all so much for your time. I appreciate it.